This
Who are going
conference
to
will
be
now be
calling
recorded.
in on the phone and will be attending in a teleconference session. Will the folks on the phone, will the commissioners on the phone identify themselves for the record?
This is Commissioner Stephen Thomas.
Commissioner?
Michael O'Grady.
Commissioner O'Grady.
Commissioner Jeff Metz.
Commissioner Tamarchio.
Commissioner Tamarchio.
Bob, did you hear me?
Commissioner Metz, yes, I've heard you, yes.
Thank
You're
you.
recorded as present. You're recorded as present.
And Bob, did you record Stephen Thomas as present?
Yes.
Thank you.
Okay, very well. Very good. Fellow commissioners, let's turn to the minutes. Included in your packets are copies of the minutes from our October 16th, 2018 public meeting. I would, you've all had a chance to read the minutes. I'd ask for a motion to approve the minutes. Do I have a motion? Motion is second. All those in favor, say aye. Any opposed?
Aye.
Aye.
Okay. At your suggestion, on the at last month's meeting, the September 20th minutes were revised to better reflect the conversation of the commission, and they were posted on the public website and the commission page. Do I have a motion to approve the September 20th minutes? Motion, second. Any further discussion? All those in favor say aye. The ayes.
Aye.
Anybody opposed, I should say. No one opposed. Okay, fine. The minutes are adopted. Thank you. Commissioners, you've all received written updates from the various centers. You've had a chance to read these updates and absorb them. Do you have any questions about the written updates? Anything you have read that has raised a question in your mind?
But then come like 6 o'clock at night, I'm like, God, I had 6 hours ago.
Okay. The executive director may have some additional updates, and any of the center directors as well. Director?
Thank you, Mr. Chairman. We have a lengthy agenda today, and I want to recognize the whole staff who helped us get this going. We have some new presenters today for the first time with our CON team. And we also are going to showcase some of our public reporting initiatives, some of which have garnered some public national attention. So I'm excited for the staff to preview that. It would be also negligent of me to point out that we are going forward with a number of regulatory actions. Most notably, last month we voted to adopt proposed final regulations for the state health plan for comprehensive care facilities. We expect that those regulations will be published in the Maryland Register on December 7th. There would be a 30-day comment period, and after that, the Administrative Executive Legislative Review Committee in the General Assembly would have an opportunity to look at that. We expect to continue to have conversations with individuals in the nursing home community regarding these regulations, and do expect some comment during the formal comment period in December and early January. I'll also note that you're going to be hearing for the first time today proposed draft recommendations for the CON task force. We will have several opportunities to bring that to you today is the first opportunity. At a meeting on December 3rd, we will share your input with the task force members, and they would adopt the final proposed draft report that we would present to the commission on the 20th of December.
And I'm sorry. There's somebody online is not on mute, and we can't hear anything you're saying. That's Ben?
Yes, Commissioner O'Grady.
Yes, I was just saying, somebody's not on mute. We kind of missed your entire statement because, we're hearing somebody's, kids home from school in the background. So I assume everything's cool, but we just missed the whole thing. So if whoever the other people on the phone are could just put it on mute, we'd be able to hear the commission meeting. Thank you.
I think you characterized it that everything is moving ahead. These are significant changes. We have structured them in a way that the recommendations are characterized as activities that can be started immediately, those that could be adopted through statutory changes in the midterm, either in this legislative session or in 2020, perhaps later in some instances. And those recommendations that we anticipate will require further engagement with our other state partners going forward. So most importantly, the Commission would have several opportunities to review these before the report goes to the legislature. Hope that helps.
Right. Have the record show that everything's cool. Do any of the other center directors have any additional updates? Anybody? No? Okay. All right, listen, before we go into, excuse me, Megan Renfrew. All right, okay, but yeah. Okay, I'm sure you have something exciting to tell us.
So I wanted to come just to give you a brief update about the work we're doing with MIMS related to EMS delivery of care and potential reimbursement for some of those new models, existing models of care delivery. In the spring, the legislature asked us to study this issue, and our report is due on January 1st. So I will be coming next month with a report for your review, but I just wanted to do a quick, lay a little bit of groundwork and review of what we're studying so that next month it'll be top of mind for you. So just as a reminder, we're looking at 3 models of EMS care delivery that do not currently obtain reimbursement under most forms of insurance. These 3 models are mobile integrated health, which are programs where EMS partners with other care providers, which may include nurses, nurse practitioners, social workers, doctors, and community health workers, to provide in-home care to individuals who are frequent users of the 911 system, frequent ED users, or who are at risk for readmission at hospital discharge. And the goal is to address health issues with the patient and in the home that could cause increased risk, and also to refer the patient to resources, including primary care, that are needed to help reduce their utilization long term. Secondly, we're talking about alternative destination programs. These are programs in which EMS would be authorized to, using a protocol set by MIMS, to identify low acuity patients who would call 911 and ask with some sort of issue, but that where the issue could be appropriately cared for in a non-ED environment, most likely an urgent care center. Currently, most insurance reimbursement rules only allow for reimbursement if the transportation is to the ED. So this would be a change from, this is a change, those programs are a change. And then finally, we've been talking about reimbursement for treat and release. this is something that happens right now, where patients may, after EMS responds to their call and perhaps provide some level of treatment, they may refuse transport. And EMS, because of the reimbursement model is based on a transportation model, they don't get any reimbursement, even if they've expended time, care, supplies on the person that they've treated. And the frequent example here, which I think would resonate with many of us in the room, is when EMS responds to an opioid overdose, provides Narcan, the person revives, and then they refuse transport from the ED. And so EMS is out for the Narcan and the care, but doesn't have any reimbursement model for that. So there are a number of pilot programs happening in the state with respect to mobile integrated health and alternative destination. There's 7 mobile integrated health programs and 2 alternative destination programs, one of which is authorized but not yet funded. Authorized, funded, but not yet running. And so they're being piloted now. But the current funding models for mobile integrated health and alternative destination programs is based on grants. So it's not sustainable long term. So the question for us was to look at what reimbursement would look like, or the process. We were specifically asked to identify a process for Medicaid and reimbursement, a plan for Medicare reimbursement, and then to study the possibility of private insurance reimbursement. So we have held a number of meetings with state agencies over the course of the summer and fall, because it requires a lot of in-state coordination to figure out these issues. We've had 2 large work group meetings at this point, and we'll have another right after Thanksgiving, and then have had a number of small meetings, one-on-one with stakeholder representatives, including insurers and MHA. And then timeline-wise, we plan to, so we have that one more work group meeting in late November, and then this will go to the MIMS board on December 11th and to our meeting on December 20th. And that gets us to the January 1 date. So I think that's all I want to share right now, but we will be coming to the table with recommendations in a report next month. Yes.
Thank you. Any questions? Yes. Mr. Pauly.
So at that point, it seems like that's a late point for us to weigh in. So if we have, we're going to be, it sounds like we're going to be handed a list of recommendations to stamp.
That's fair. I can get you all let me think about what this. So I mean, I can certainly get everybody something well before our normal mail date, right? Because if we're going to have something that goes to MIMS several weeks ahead of time, I can get it to you all ahead of time too. The report isn't fully drafted yet, so I can't produce something today. But that's a fair point. And I'll talk to Ben more about process.
Are the payers at the table?
So we've had a number of one-on-one conversations with a variety of payers and the League of Life and Health. They're in the room for the work group. Deb is doing her one. I mean, we've got Deb, Tina, a whole bunch of folks involved who are being quite vocal.
Well, I'm not getting too far into the weeds on the thing, but the idea that the payer is going to pay an ambulance bill to take a patient to an urgent care center when Uber could do it for far less.
Right.
I mean, I think I would have concerns about mandating something like that. I'm guessing that others at the table might also. I don't know.
Yes,
but
I would.
I think we anticipated that concern, and I've certainly been taking it into account in our conversations with our state partners.
Okay.
Thank you.
Mr. Director?
Yeah, I think it's a challenging topic to push forward. The record should show that the Healthcare Commission staff said this is really at least a 2-year study, given the complexity of the issues. But the legislature opted not to follow our advice, and we're getting a report out, but I think what it's largely going to conclude is more studies needed. So there are some very limited opportunities for use of this ambulance code of treat but no transport that has been adopted by Anthem nationally. They've indicated they would pay for that. There are also moves afoot in Pennsylvania to do something similar, but there are cost concerns on the part of payers and on the part of private payers and Medicaid that will be have to be addressed before we can do this. We've heard loud and clear, and we've emphasized that we thought that it should, if it is something that moves forward, it should not be as a mandate, but rather one that is adopted by payers, public and private, on a this makes sense basis. But we'll have to wait and see how this all plays out. No one is currently doing this in Maryland, although, as I noted, it's happening elsewhere in the country.
Thank you. Any further questions?
Thank you.
Okay, thank you very, very much, Megan. Thank you very much. Commissioners, we're going to be voting on some sensitive matters today, as we always do. If, for any reason, you feel that you have to recuse yourself, please announce the fact and then leave the room while the agenda item is being disposed, one way or another. And then the staff will come to the conference room and retrieve you so you can come back and continue the meeting. Once again, it's your judgment, but if you feel that there's an appearance of potential conflict of interest, to announce that fact for the record and remove yourself, okay? All right, next item is the database, the data submission manual. Each November, the Commission formally updates the medical care database submission manual for the upcoming year. The submission manual is designed to help reporting entities with technical specifications, layout, definitions necessary, the requirements that they must follow under our regulations in filing these reports. Ken Yates Trotman, Acting Director for the Center for Analysis and Information Systems, is going to present updates to the manual. Ken, the show is yours.
Thank you very much, Commissioner. As an overall overview, I will talk about the overview background and refresh the memory on the reporting of the requirements, review changes that was made in the manual, and also seek your approval. As stated in the regulation, Maryland Healthcare Commission is required to provide the submission manual by November 21st each year to be used for reporting periods in the subsequent year. The Commission shall timely post the manual on the Commission website and provide notice in the Maryland Registry. What is included in the MCDB? The Commission collects healthcare data from privately insured reporting entities whose total lives exceed 1,000, as per reported in the Maryland Insurance Administration. These reported entities include life and health companies, HMOs, third-party administrators, PBMs, and behavioral health administrators, and also qualified health and dental plans. Healthcare data is reported in the form of membership or eligibility file that houses all covered members, regardless of if a member incurred a claim or not. The claims are reported in terms of professional services, institutional services, pharmacy, and dental. We also have a provider file, which includes but not limited to payer identification and NPI. We also have a non-fee-for-service, which we have not acted as yet. This is still in the future. The Commission also collects public data from Medicaid, which provides which is provided by the Hilltop Institute, and Medicare data, which is acquired by the state agency UA with CMS. What is changing? There are no material changes in Maryland's 2019 MCD reporting requirement, except for a few reminders. We're reminding all payers to protect the confidential information of all covered members in all MCDB data submissions. We are achieving this action by enforcing regulation, requiring all payers to attest all MCDB database submissions to exclude unencrypted patient identifiers. Each attestation by payers will be made via the MCDB portal, and this attestation will cover all submissions, resubmissions, and then the attestation excludes the CRISP demographic file. As far as feedback from payers, there was no negative feedback. Some payers only asked for some clarifications on what they are attesting to. We continue to promote timely data submissions by explaining to payers that all submissions must pass all data validation checks on or before the final submission date. And we continue to enforce our finding authority for seriously delinquent payers. The next step, we ask the Commission if you have any questions and ask for your permission or vote in posting the submission manual on the Commission website. This manual will be disseminated with follow-up meetings with payers in early January, and these changes will reflect in the first quarter of 2019.
Thank you very much, Ken. Are there any questions for Ken? Any questions at all? Any of the commissioners on the phone have any questions for Ken Yates? Okay, we have a motion before us, a motion to approve the release of the data submission manual. Do I have a motion to release? Motion. Have a second? Any further discussion?
Second.
All right. Any further discussion? Fine. All those in favor of releasing the manual, say aye. Aye. Are there any opposed?
Aye.
Aye.
That's fine. I think they get the message. All right. Everything's cool after all. All right. Thank you very much, Ken. Next item is the diabetes measure and potential for Maryland. The issue here is that under the total cost of care model, the CMS in Washington and the state of Maryland will test whether the statewide healthcare delivery transformation will improve population health and healthcare outcomes for individuals, while at the same time controlling healthcare costs in the state of Maryland. The state will be responsible for addressing at least a minimum of three populations, the priorities for three populations among Maryland residents. One of the priorities is going to be the reduction of the prevalence of diabetes. Ms. Judy Lauren, who is our contractor, analyzed the feasibility of using our database for tracking diabetes prevalence and monitoring the cost of treating Maryland's non-elderly, privately insured diabetics. Welcome, Judy. Thank you very much.
Before we begin, I want to recognize that we are doing this at the request of the Health Services Cost Commission that will be responsible for the population health measures and reporting to CMS. I want to note the important work of the staff here in the room, Ken, Janet, Mahi, and others as well as the participation of Commissioner O'Grady in this effort, and also the leadership of Linda Barniska in getting this started. So this is something that is important for the state in the compliance with the model. And what our goal here is not to necessarily highlight actual performance, but demonstrate the capabilities of this data system to support it.
Okay. Thank you very much. Judy, the floor is yours.
Thank you, Commissioner. I'm just questioning how the slides get advanced. Great, thank you. Okay, so my background is that I'm a data analyst. I've been working with healthcare claims since the early 2000s. So I was really enjoyed digging into the Maryland APCD. So I gleaned from looking at the website that the new total cost of care model has 3 goals that we can address with some of the assets that we have on hand. And so this presentation is going to just talk about some potential ways that the information in the database and the ACG software can inform your efforts to achieve these goals. So the assets that we're looking at are, of course, the medical care database that Ken has described, which contains information on Maryland residents that are covered by insurance. You can't get the information on people who are not covered. It contains data on privately insured as well as Medicaid and Medicare. This study is just going to focus on the privately insured adult non-elderly population. And then applying to that data is the Johns Hopkins ACG system, which is makes available an ability to measure the expected cost of people based on their illness burden, but in addition creates a lot of very convenient population health markers that we can use. So this example is just focusing on type 2 diabetes. So the first goal of controlling costs involves a couple of things, because you can monitor just the cost of diabetes, but if it changes from one year to the next, you don't know whether that changed appropriately or inappropriately, because there's inflation, there is risk, there's aging. So you also want to follow the cost of the total population, and then you can say, did the cost of the subpopulation with diabetes change differently from the overall cost of healthcare? So that's what we call the secular trend. And then we have the concept of risk, and I don't know how much technical background everyone has, but I use the term risk, which is basically an estimate of the additional cost for each condition or illness that a person has. We are also going to look at 2 different years of data, because we want to watch how things change over time. And there are 2 ways of doing that I'm going to be highlighting here. One is to just look at 1 year and look at the statistics for that year, and then look at another year and look at the statistics for that year and see how they change. But another is to actually match individual people over the course of time to see what is happening. And we're going to have examples of both of those. So if we want to monitor the change in cost, here are some very simple things you can calculate. For example, you can just take the average cost in nominal dollars of a person in the whole population, which in this case is showing went from $6,142 in 2015 to $6,428 in 2016, or 5% change. And then you can compare to that the subpopulations who can be diagnosed with type 2 diabetes. And at the nominal dollar level, we see that that was going up faster. Now, again, this isn't about what we did. This is about showing you what would be possible to do. But what you want to be able to do is look into that and say, oh, gee, is that a problem with, let's say, the supplies for treating diabetes? What is exactly behind that increase in cost? So the next section of this slide shows that by looking at what they call the risk score, or the relative morbidity, we can actually see that the population with type 2 diabetes, with all of their complications and comorbidities, actually increased faster in their risk level, which would lead you to expect a higher increase in the cost. And so at the bottom, when we adjust the cost for that risk level, we see that actually the type 2 diabetes population went down more than the other population. Now, there's an asterisk on this slide that's really important. which is specific to 2015 and 2016, where we changed from ICD-9 to ICD-10 ways of coding diabetes. And so those 2 years aren't exactly comparable, but this is just to show what could be done. So if you imagine this into the future where we're on ICD-10 in both years, maybe some more meaningful. So another way to drive down, kind of look under the covers at what's causing some of those changes is, as we all know, the population is aging. The ACG software automatically produces these buckets of age groups that allow you to look at, within an age group, the cost is changing approximately the same. So it's not the cost within the age group that's driving the overall cost. We see that over on the right, the count, we're growing faster in the older age population. That's not news to anyone. But it also allows you to break down in the middle, what are the differences in the expected costs based on the illness burden within the age group, as well as across age groups. Talking kind of fast. Does anybody have questions?
When you're defining your groups, are you tracking from year to year the same individuals or the entire pool?
Thank you for asking that question. On this slide, we're not comparing individuals. We're just looking at 2015, how did it break down, and 2016, how did it break down.
And the reason I ask is for fellow commissioners is the pool could change from year to year. I don't know about 15 and 16, but since most of the database stays, the individual market piece would have changed dramatically between 14 and 15 because different people were coming in, and if everyone is getting sicker, it might undermine an argument, like trying to focus on one particular condition.
Well, and that's a really good point. I mean, in the overall database, you've got your residents of Maryland, and that's going to change a little bit from year to year. You can isolate certain plans and say, within this plan, here's what changed, and you can feel that maybe for certain plans, there's a lot of continuity, and other plans there isn't. So you can break this down further. In the database, it's the plan paid amount and the member responsibility for all fee-for-service claims. That's in here. Yes, it is. Yes, for that individual. Yes. Thank you. Other questions? Okay. So one of our goals might be to estimate potential savings. And there are lots and lots of ways of going about this. This is a very, very simple example, but it just says, what is the cost of complications? And at a very high level, you can simply say, well, what is the average cost of a person who has type 2 diabetes but no complications? And what is the average cost of a person who does have a complication? And by looking at that difference, you can say, here's your potential savings. That can give you a sense of what it's worth to invest to prevent a complication, something like that. Very high level, but just an example of the kinds of things you could do. Another thing that the ACG software makes available to you, which is really nice, is they have already grouped up your ICD-10s to allow you to define, for example, the population with cataracts. And so by running the software, you can now do some fairly simple calculations, like shown here, how many people have that complication? What is the average cost of a person with each of these complications compared to people with no complications? What percentage of the people have these complications? So these are all different things that the software makes fairly easy to calculate.
Are these selected because we know that they are complications of diabetes, or because they are complications that occur with high frequency among people with diabetes? I mean, the difference being, did we say we know this happens, so therefore we're putting them in, or did we go and look and find out whether or not it's caused? Did we just pick the highest complication?
So I'm not a physician, but there was one on our advisory group, and she was the one who suggested these specific conditions.
So you started with sort of knowledge of diabetes and what it caused, and then went to...
Yes. Yep. We also did, what you're seeing in these slides is a small harvest of all the tables we produced. And we also produced a table of conditions that diabetes tends to exacerbate. So they're not complications of diabetes, but they're things. And so we have another table like that in salt fraction.
Can you also look at, do the study with pre-diabetes? Because looking at the group that you could have the largest bang for your buck to buck, essentially, in preventing them from getting to diabetes.
That's very perceptive of you, because that came up in the advisory group. And I will say the ACG software doesn't make that as easy to do. But the database has the information necessary. If you had a clinical person who could tell you, look for these ICD-10 codes, so that's not part of the ACG software, but it's in the data. And so a programmer could do that, but we couldn't do it easily.
Okay. Any further questions? Judy, continue.
The second goal after cost was to prevent the chronic condition. And so what are some of the measures that would allow us to determine whether that's happening or not? We want to monitor the prevalence and then, the newly occurring cases. And again, talking about estimating potential savings. So this is comparing with the Behavioral Risk Factor Surveillance Survey that the CDC does. What we're able to do is say, within our database, what do we see? And what does BRFIS say? And they're not the same here, because the question that gets answered on the BRFIS survey is, has a doctor ever told you you have diabetes? So they don't distinguish type 1 from type 2. They don't require that you have a claim with that diagnosis on it. So they're going to have a higher rate than we are going to see in the database. But we're seeing similar increases by age group and things like that, which tends to validate the data and the software that we're using, because we're finding consistent information. Okay.
Is there much prevalence of undiagnosed type 2 diabetes? That would come into, I guess that would come into the without in this case, it has been diagnosed.
I don't know if Commissioner O'Grady is on the phone right now, but he did bring that up several times.
I am.
Yeah. Mike, didn't you talk when we were having our advisory group meeting, saying, the claims are only part of what's actually out there in terms of diabetes?
Right. It's Randy, in terms of thinking about the undiagnosed, that data normally you wouldn't get it off claims, of course, because you're not seeing it. The CDC does run a survey called NHANES, which I believe we have access to, although it's kind of a bear to work with sometimes. But that actually takes blood samples, and so that's where the undiagnosed estimates come from. And it's fairly high. It's disturbing, but they actually take blood from the people in the survey, they analyze it, and they can see that the person has, they have an ethical dilemma. Do they tell the person they have type 2 diabetes? It is a little bit of a violation of the privacy stuff. At the same time, but that's a very expensive, very extensive survey that actually goes around weighing people, drawing blood, those sorts of things. But the estimates are available. I don't think they'd be available at the state level, though. They are pretty much national.
So you'd have to go with rate. So this slide just shows that, you can look at it geographically. And again, I don't think there are going to be any surprises on this slide where in Somerset County you have your highest rate, and down in Montgomery County you have your lowest rate. But by being able to look at it at the county or the geography level, again, you can monitor it and compare progress. So this is a slide where we did match. We matched individuals in 2015 and individuals in 2016 so that we could determine newly diagnosed cases and then look at their costs. So the top row is people who did not have diabetes every year. What was their cost? The second row is people who we have their 2015 records, and there was nothing in 2015 to suggest they had been diagnosed, but then in 2016 they were. And then the bottom row is people who were diagnosed in both years. And what's interesting to me is that the cost of a newly diagnosed case is not low. I would have thought those were people who were beginning the course of the disease and maybe not too many complications. But as Mike pointed out, they could be either, gee, you're newly diagnosed, we better check a lot of things, and so we kind of throw a lot of diagnostics at them, or they could be fairly well advanced and they had never been picked up before. So I thought this was informative. But again, this is the kind of thing that you can do going forward is, are we reducing the newly diagnosed cases? Are we finding them better? Are we preventing them? So, another way of estimating savings. What this slide does is, using that same comparison of a person with diabetes compared to a cost without, but then I calculated it out as a percentage of the total healthcare budget. To say, 5% of cases is a lot to prevent, but it's 1.13% of the entire healthcare budget could be saved. So it's just a different way of calculating estimated savings. Might be helpful. And the third goal that I gleaned from looking at the total cost of care model was improving care coordination. And I think one of the struggles there is, how do you even measure care coordination? And then how do you associate a cost or a savings with it? So one thing that the HCG software does that I found valuable was that they estimate care coordination by looking at the number of distinct docs a patient saw. And of course, that's a little complicated, but if you have diabetes and you're not seeing a doc at all, that top row where it says unique provider count of 0, you're encountering the healthcare system, but you're not having face-to-face visits with a PCP, your cost is actually going to be higher than someone who may have diabetes, but it has a PCP. That would be that second row, unique provider count of 1. You go into a single doc, maybe you go multiple times, but that care is fairly centralized in one individual. As you go down through this table, you find people who are seeing 2 docs, 3 docs, and 6 docs. But it could be they're seeing them because they have a complication, right? So how do you tease out the increase in costs that's due to those complications versus the increase in costs that's due to seeing too many different docs and having your care not coordinated? Well, that's where the risk comes in. If you look at the risk, you say, this is the amount of extra cost that is assigned to you because of your other conditions. Factor that out, and you can still see in this last column an increase in cost associated with seeing lots of docs. So I think this is a good way to get at care coordination. What are the costs of it, and what are potential savings? Any questions on this slide? It's got a lot on it.
Dr. Peters first.
Is there a way to look to see if the patients in the first year had coverage in the year prior? Because if these are all new cases, then either they weren't followed and they're really sick and they're really diagnosed.
Yeah, so on that slide, I did in fact choose only people I knew were there both years. They were on the eligibility file in 2015 and in 2016, so they had coverage.
Okay.
Right.
Dr. Pollack.
The difference between seeing 6+ docs, 6+ providers after risk adjusting is much greater than the difference than seeing 0 than is the difference between 1 and 6. The difference 1 and 6 is rather small, which begs the question: is this inadequate risk adjustment? And the truth is that what's really up here is that seeing 0 is your biggest risk. Or is there care coordination in here that makes a difference?
Well, I certainly think that seeing no doc is very dangerous.
Right.
All risk adjustment is inadequate. I'll just make that statement. We try.
And I think that's what you've shown there, is that all risk adjustment is inadequate.
But
to say that there's a care transition problem here in that data, I mean, I'm not sure you can get that out of that data. There might be. But that's a pretty small difference, 292 to 335.
Yeah, 15% more, right?
Right.
Right. I'm
insignificant compared to the cost compared to that.
No doc.
Yeah.
I think that we could look into the data and find out what these people who are seeing no docs are doing. Are they just showing up in the ED? Are they, getting ED to inpatient and they're not having any, and then once they leave, they're not having a visit back and things like that.
I'm just nervous about drawing a conclusion about care coordination given that data, given that how tight that is between 1 and 6. Well, that's what the risk adjustment is supposedly correcting for, and that's what I'm saying. Is it inadequate? Is it adequate risk adjustment? And we know it's not.
You know what else would be good is to look at practices. You know, if you're seeing 6 docs, but they're all in one practice, versus you're seeing 6 docs in 6 different geographic areas, you know, you could dive into it in that way.
True. I'm just nervous about drawing a conclusion about care coordination from that slide.
I think that's a fair point.
Okay. Any further questions? Yeah, Judy.
So this is my closing slide, which is just restating the 3 major points from the model, and then indicating some of the things that the combination of the APCD and the APG software could do. There will be a final report where we will have a much richer set of tables that we put together, and I assume that would be available to the commissioners to look at. Yeah. Before the end of January.
Okay. All right, very good. Mr. Director?
Yes, so at the outset, we talked. The chair talked about diabetes as being one of the population health measures that is already incorporated into the model. The actual population health credits that hospitals would receive for better managing patients attributed to them with diabetes will be limited to the Medicare population. But if you are launching a broad initiative to reduce the prevalence of any condition, really you have to look at it more broadly, and successes in controlling the onset of diabetes in the under 65 are probably going to be key to individual hospitals realizing credits or losses on the growth of diabetes in the over 65 population. So we think this is important to bring in to the discussion. There will be a statewide meeting to sort of kick this off on December 4th, and the state is seeking broad engagement for that work. Diabetes is the first population health measure that will be rolled out, but there will be opportunities to suggest others as well that could, over the course of the next several years, be incorporated directly into the model.
Any further? Oh, yes. Any further one? Dr. Pollack.
To that point, are there important examples that you can point to of hospitals being successful in reducing the prevalence of diabetes within a patient population attributed to it by some model?
This attribution concept is really unique to Maryland. I'm not aware of others approaching it this way. Certainly, the concept though is not foreign to health plans, and the attribution is much more specific and linked to a health insurance policy. The question is, can we, through this model, really reward and penalize hospitals for reductions in the prevalence, in which they may have a much more indirect relationship to those patient populations than, say, one might expect from a payer? I think that's a very tough question to answer at the outset. We're going to be the first, I think, experimenters on this across the country, and a lot needs to be worked out before this rolls in beginning in 2020.
Yeah, I think the attribution model is what, as you point out, is what's key here. In a payer relationship, the individual is signing up for and potentially even paying for coverage from an insurer, has established his own relationship with the insurer. In the current attribution model, the patient may not even be aware of the fact that he or she is attributed to a particular healthcare system or hospital in this case. So the idea that hospital can influence that patient's individual behavior in a way that causes him or her not to get diabetes is just I mean, it's possible, anything's possible, but it's a stretch to some extent to think that the hospital has the influence to do that. I mean, maybe if you give the hospitals local zoning control so that fast food restaurants couldn't be put up in that particular neighborhood, but I don't see anybody giving that zoning control. And I don't mean to impugn fast food restaurants as the cause. I understand it's a public meeting, but
This is where Amazon is going to disrupt
It's a
healthcare.
public meeting, yes.
Yeah.
Commissioner Sargent. Yes.
I say this is how Amazon is going to disrupt healthcare.
So I think, just to respond to Dr. Pollack's comment, and this whole concept of attribution is one in which we want to slowly unfold to the commission. That's a topic that has been discussed at HFCRC extensively. The attribution would trickle down to physician practices affiliated with that health system, but Dr. Pollack's point is right that ultimately, a patient that visited Good Care Memorial may leave that hospital with less than a pleasant flavor in that patient's mouth, and the desire to be attributed to that hospital as opposed to another hospital is going to be difficult to sort out. There's also, and we'll just highlight this as an issue that we will bring before the commission as well, is the issue of data sharing. That will be necessary to make this work, that there's going to be significant need for data sharing between health providers intrinsic in this initiative that needs to be ferreted out, understood, and patients engaged. So just the first of many conversations on the population health credit in my mind.
Any further?
Just a quick question I have.
Yes. Commissioner Raymond.
Bottom line on this is what we're looking at. This is an analysis of diabetes, but the ultimate goal is to eventually take this type of a model or this type of information and use it in the total cost of care concept as we're moving forward, some way to monitor and maybe use it in the rate setting side, or at least look at the overall cost based on a population with certain.
So correct. So if you have a population health measure, by definition, it should cover the entire population affected by that. But at the outset, the outcome credits, the population health credits, are going to be limited to the Medicare population only. Our point in HFCRC's discussion with us has been, if we were going to launch a initiative to improve population health, we have to reach into the non-Medicare population to try to address it. So we don't expect that outcomes on the under 65 population will directly impact hospitals on these outcome credits immediately, but they could over time. But to be successful in these initiatives, you have to deal with the population that's going to be affected.
So the issue is somebody below 65 will be 65 one day.
Soon,
So,
yes.
We've got to, understand that just focusing all the time on Medicare may not do us a service in the next 10 years.
Yeah. I think that's very succinctly put as to why you want to look below the age 65 population. I think Commissioner.
Excuse me, can I?
Commissioner O'Grady, go ahead.
Yeah, I just wanted to jump in on a couple of points here. One, in terms of the work Judy did here was to take a first step in the water on this database, and I think it was very successful. I think Commissioner Pollack brought up a number of things where you'd want to do a deeper dive to not kind of an implied causality that isn't really there on things like the number of providers you see. It's also important to keep in mind that we identified potential savings, but not necessarily the cost of, you have to spend money to make money. And so there is this idea of, is there $1,000 per capita, et cetera, but most diabetes interventions are fairly expensive. And therefore you have to think about that in terms of what that return on investment is and how you do that. Not to say you wouldn't want to do it anyway, just for the clinical advantages you get. But I do think that diabetes is a good one to think of first because it's very expensive, it's very prevalent, and there is a potential to both get good clinical outcomes and good cost out savings involved, or at least less spending. And so I applaud that this is sort of the tip of the spear in this sort of area. But I think with Commissioner Pollack's point about not expecting results from people who have so little control over the process. You know, the literature in this area is much more supportive of not so much that a hospital could control the prevalence of diabetes in their catchment area, or however you want to think about it, but how that treatment is done once they're actually, you know, they have them. And unfortunately, given that same dynamic that you talked about just now, Ben, about pre-65, post-65, there has been a culture, which is changing, but it's been wait till they break, then fix them, rather than getting in there early and doing some of the things that would avoid some of these, you know, ugly and expensive complications. And that gets back to your dynamic about pre and post 65. That, you know, the payers who pay for treatment pre 65 are very different than the payers who pay post 65, and therefore to ask commercial payers to pay money for something that will save Medicare a decade from now is just a very tough nut to crack.
Thank you very much, Commissioner. Commissioner Tamarkio has a question. Commissioner? All right. Anybody else have any questions? Well, all right. Thank you very, very much, Judy. That was excellent. Thank you very much. Commissioners, the next item is a report being prepared for our release on the Maryland Trauma Physician Services Fund. In 2003, the Maryland General Assembly enacted legislation creating the Maryland Trauma Physician Service Fund to help Maryland's trauma system by covering trauma hospitals on call for trauma expenses, reimbursing trauma physicians for uncompensated care losses, and raising Medicaid payments to at least the Medicare rate when a Medicaid patient gets trauma care at a designated center. The law requires our commission and HSCRC to report on the status of the trauma fund each year. So Bridget Zombro, our Chief Operating Officer, and Denise Ridgely, Program Manager, will present the report. Bridget?
Thank you, Mr. Chairman. Good afternoon, members of the commission. Today, Denise and I will present the highlights from the Maryland Trauma Physician Services Fund annual report.
Can you speak a little louder or come closer to the mic?
Yep. So I prepared an extensive background slide on legislation. To this point, I'm not going to read through all of them, but I know a couple of our commissioners had some questions on the fund last month, so I wanted you to see the enabling statute and the changes in the legislation since that point. So I'm going to skip through that. And what I say is the enabling legislation, simply put, provides payment to offset the cost of uncompensated and undercompensated medical care provided by trauma physicians to patients at Maryland's designated trauma centers. It provides a stipend to trauma centers to offset the trauma centers' on-call and standby costs. It provides grant funding to trauma centers for certain equipment. And it reimburses Medicaid for the state's portion of Medicaid underpayment, the difference between 100% of the Medicare fee schedule and the Medicaid rate.
So just to provide you with a little bit of information on the resources of the MHCC. As you know, every trauma patient is assigned a trauma number at the point of entry. NIMS on a quarterly basis reports that data to us. CoreSource, who is our third-party administrator for the uncompensated care claims. Myers and Stafford is our auditor. They audit practices and trauma centers. Medicaid submits reports on the state share for managed care organizations and fee for service reimbursement. And the Department of Motor Vehicles reports to the MHCC on revenues projected and collected. And then the Comptroller's Office is responsible for disbursement of payments from the trauma fund. Some key points on revenues. The surplus funds carried over from fiscal year 17 totaled about $10.4 million. Fiscal year 2018 revenue from DMV totaled approximately $12.5 million. And fiscal year 2018 credits to the fund were approximately $87,000. The total surplus at the close of fiscal year 2018 was $11 million. It is to be noted that during the 2018 legislative session, the Budget Reconciliation and Financing Act reduced the fund balance by $8 million. Going forward, at the beginning of 2019, our surplus then was at $3 million.
Key points on expenditure. Expenditures during FY 2018 totaled around $11.9 million. I do want to let the commissioners know that when we receive refund checks back from either trauma centers or trauma physicians, those credits are put against our expenditures. So expenditures could be a little bit higher, but we do credit those to expenditures. And that's basically to keep within our $12 million appropriation. Uncompensated care expenditures totaled roughly around $1.6 million. On-call expenditures totaled about $7.9 million. Payments to Medicaid totaled $1.1 million. But I want to note that that included about $1 million adjustment to Medicaid for underpayment of facility fees during FY 16 and 17 and professional fees. Children's National Medical Center standby totaled $590,000, and trauma equipment grants that were given out was about roughly $600,000. The administrative expenses to the fund, which is the invoices for our auditors and our third-party administrators, totaled about $107,000. Going into 2019, the appropriation for expenditures is $12 million. The next slide kind of illustrates the increases and decreases that the commission's made over the years in reimbursement. During fiscal years 2003 to 2009, reimbursement rates were 100% of the Medicare rate for the Baltimore region. Fiscal years 2010 through 2015, reimbursement rates were reduced to 92% of the Medicare rate, and that was due to the turn down in automobile registrations and renewals during that period of time. With the exception of Medicaid. Medicaid was never lowered to 92%. Fiscal year 2016, the reimbursement rates were restored to 100% by the commission. And because of the ongoing surplus in the trauma fund during fiscal years 2017 and 2018, reimbursement rates were increased to 105% of the Medicare rate, with the exception of Medicaid.
So on the horizon for the trauma fund, we are going to revamp the trauma registry data processes that support CoreSource. We would like to redesign the trauma page on the MHCC website for education and training purposes, kind of make it a little bit more user-friendly. We also plan to get more involved with the trauma community, gathering information and possible recommendations to allow us to allow for trauma-related uses of the fund.
So staff asked for the commission's approval on four things: to continue the reimbursement rate for uncompensated care and on-call at the 105% of the Medicare fee schedule, to pay Medicaid underpayment trauma claims using the same payment rates and policies that apply to uncompensated care claims. So the reimbursement rate would be increased to 105% for those claims. And to pay second and subsequent procedures on Medicaid trauma claims using the same payment rates and policies that apply to uncompensated care. So what that means is secondary procedures would be reimbursed at 105% of the Medicare fee schedule. So there would be no reduction to the procedure fee for second procedure. And finally, we ask that you release the report. This concludes our presentation. Happy to answer any questions. And if you don't mind, I'd like to introduce Brian Zanzak from my staff. Brian did a lot of work on the trauma report too, so I want to recognize his contribution.
Thank you, Brian. Thank you very much. Commissioners, Commissioner O'Connor first, and then Commissioner Boyle.
Where did that $8 million go after that Reconciliation Act?
You know what? I did not ask what they did with it.
They don't.
So the
It just goes right into the general fund.
well, so the budget request was for supplementing the physician fee schedule under Medicaid. That doesn't mean that fee schedules will increase, but it means that the revenue that was held by the trauma fund was moved into the Medicaid budget for reimbursement purposes. And since Medicaid funding comes from general fund, one might think that general funds needed was reduced by $8 million.
Okay. Commissioner.
Why was there such a surplus in the beginning? I mean, plus $8 million, but
over the years, the trauma fund, I would say with the enactment of the 2014 ACA, kind of reduced people not having insurance, less uncompensated care. I think that's a large part of it.
Oh, Commissioner Pollack, you have a question? Go ahead.
I just have a response to that. So the Affordable Care Act decreased the number of patients who were uncompensated and transitioned a bunch of those patients from the pure uncompensated role to, in this case, in the trauma fund case, I think we've argued about whether that's true overall, but at least in this case, to the Medicaid roles. And the Medicaid system bore the brunt of that additional cost, which is why the argument was to move $8 million from here to the state general fund to support Medicaid, because Medicaid had been bearing the brunt of what was previously covered by the trauma fund. The problem was that under the Medicaid billing rules, which matched Medicare billing rules but not Uncompensated Care Act billing rules, the total amount that was reimbursed to physician practices dropped dramatically during that time, which is sort of the reason for the correction that we just that's being proposed right now. But the real reason that surplus grew is because the burden moved to Medicaid, which is why I think nobody really fought very hard last year when the $8 million moved into the BRFA.
Thank you very much for that clarity. Yes. Are there any further questions, Bridget or Denise? Any further questions? Okay. Well, thank you very much. The issue is the approval of the release of the Maryland Physician Services Trauma Fund report and the recommendations. Do I have a motion? A motion. Do I have a second? Second. Any further discussion? All right. All right. On the motion, all those in favor of releasing the report say aye.
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 Okay. Aye. Any opposed? The report is released and the recommendations. Thank you. The next action is a request from Coastal Hospice and Palliative Care for a project change after their approval of a certificate of need. Coastal Hospice and Palliative Care applied for a modification of their existing certificate of need to increase their project cost. Eric Baker, our program manager, will present the staff recommendation. Mr. Baker.
Thank you, Chairman Moffett, and good afternoon, Commissioners. Coastal Hospice presents a modification request which seeks approval for a capital cost increase on a project approved by the Commission on December 21st of 2017. The Commission granted Coastal a CON to renovate an existing building, to construct a 12-foot hospice house residential facility and outreach center in Ocean Pines, Maryland, located in Worcester County. Coastal originally required a CON because the total expenditure exceeded the threshold of $6 million, then in effect for all non-hospital healthcare facilities. The building purchased to become the hospice house was an abandoned 3-story shell, and the property has been owned by a bank and stood vacant for 10 years. The Commission approved this building project at a cost of just under $8 million. As work started, it was determined that the building required significant demolition, additional site preparation, and renovation. Increased capital costs have been incurred to correct a series of found conditions which emerged. Specifically, the key conditions that require correction are some of the roof trusses over the existing building were not built to specification, and they were not fire treated, and that actually required demolition on one side of the building. Demolition revealed additional structural problems requiring additional support beams and lintels to be installed, and termite damage was revealed requiring treatment and prevention efforts. The public sewer line is above the sewer line exit from the building, and that required a pump and a backup pump to be installed. All air ducts and electrical systems in the building had to be replaced, and the geothermal units that were present in the building at purchase had to be scrapped due to a problem with mold. The communication systems for the nursing and EMS were found inadequate as planned, and necessary permits that were required were not anticipated in the budget. At this time, Coastal requests authorization to increase total project costs by approximately $580,000 to around $8.6 million, which is an increase of about 7.2%. Coastal states that it expects to fund the increased capital costs with a combination of increased cash and philanthropic contributions that now seem likely to exceed what the applicant budgeted. Coastal also has the option of increasing the amount of the mortgage above the amount estimated in the application. With regard to the regulations, there are several situations that may require Commission's approval for modification, but there's only one that applies, which is regarding a capital cost increase that exceeds the CON approved capital cost plus the allowed inflation factor. Using the building cost indices in effect of July 18th of 2018, produced an allowable inflation level of just over $110,000, far below the project cost increase of $580,000. So it is staff's opinion that the proposed modification will not have an effect on the Commission-approved CON with respect to the cost effectiveness of alternatives or the economic viability. With no change either in location, capacity, or nature of the project, the request will not change the need for or its impact on existing providers. The increase in project costs will not impact the costs or charges, nor the financial viability of Coastal after project completion. And Coastal Hospice has sufficient financial resources available to implement this project. Therefore, staff recommends that the Commission approve the proposed modification of the certificate of need that was issued to Coastal Hospice. At this time, I would like to introduce the following Coastal representatives: Elaine Catton, President of Coastal Hospice, and Sue Olisar, the Finance Director.
Okay. Yes. Yes. Please sit down.
At this time, I would be pleased to answer any questions.
Well, thank you very much, Mr. Baker. Commissioners, are there any questions at all for Mr. Baker? Yes. Commissioner Reimer.
Just a quick question. On the hospice house by itself, does it actually make money?
or is it being subsidized by your other hospice services? Subsidized partly by our other hospice services because we are going to have for room and board a sliding scale, and we don't intend to turn anyone away for lack of ability to pay. We also created a thrift shop that's right on Route 50 in Berlin, technically, which manages to net us about anywhere between $60,000 and $100,000 a year on any given year. And the purpose of that thrift shop is to offset the room and board.
So that's additional cost to that hospice house. Is that, I mean, just, you know, as indicating here, it's not going to increase the amount of payment required by the patients using the hospice house, but
Correct.
But again, is going to be using it, subsidize it with some additional mortgage, so it'd be some additional interest expense associated with that. I mean, overall cost for the hospice house, I would assume.
Actually, our philanthropy towards the project has gone up, and so our mortgage is actually less than what's in that budget in your project.
Okay.
In your project report.
All right. Thank you.
Any further questions at all? Yeah, these increases are normal. I mean, when you're doing a construction, you find out, oh my goodness, there are termites. You know, yes, this is fine. Yeah, that's right. We don't have any control over the termites, thank God. That's correct. Do you have any questions, anybody? Okay. All right. Well, then the issue before us is granting the project change, approving the request for a project change for Coastal Hospice and Palliative Care. Do I have a motion? Motion. Do I have a second? Second. Are there any further? Is there any further discussion at all? No. All those in favor of granting the modification for the certificate of need, say aye. Any opposed?
Aye.
All right, we got it. Any opposed? Okay, fine. You have your modification. Thank you very much. Mr. Baker, thank you very much.
Thank you.
So,
the director has a point to make. Excuse me.
stepping back to our presentation on diabetes, Commissioner Tamarcio had a question regarding whether non-physician providers are included in the cost estimates that we provided, and the answer is that yes, to the extent that they are billers, they would be included. Two specifically that she referenced were dietitians and diabetes care managers. I'm not aware of diabetes managers, educators typically billing within the scope of a nurse practitioner's practice service. That person may bill. Dietitians can bill. They depends on a situation. So the answer is, in the case of dietitians, they may be in the database. It's very unlikely that diabetes educators, care managers are billing directly based on our understanding of the claim data that we have.
Thank you, Mr. Director. The next item before us is another modification of the certificate of need. It's a request for a project change for a certificate of need for Stella Maris. Stella Maris requested a modification to their existing certificate of need to increase the total project cost. Laura Hare, Health Policy Analyst, will present the staff recommendation. Ms. Hare, the floor is yours.
Thank you, Chairman Moffat, and good afternoon, Commissioners. Stella Maris submitted a modification request which seeks approval for a capital cost increase on a project approved by the Commission on May 18, 2017. The CON authorized a project to construct an addition and small-scale renovation of Stella Maris's facility in Baltimore County. The new addition will include a 2-floor, 60-bed transitional care unit with 30 private beds private rooms, that is, on each floor.
The approved project did not change the number of licensed beds at the facility, but increased the number of private patient rooms from 114 to 158. The Commission approved this project at a cost of about $29.7 million. The modification is requesting authorization to increase the total project cost by about $4 million, or 13.5% of the total project, to around $33.7 million. Several reasons were given for this cost increase. The first being that the applicant did not account for additional inflation costs due to a later project start date as a result of this modification request. Inflation costs in construction and changes in the market conditions, adding an elevator to the new addition and making improvements to mechanical and electrical systems, the need for additional infrastructure replacements, relocations, and upgrades was discovered, and lastly, replacement of the telecommunication system and addition of a staff reporting and tracking system were determined to be necessary. Stella Maris will fund the additional cost by increasing its cash contribution by approximately $1 million and seeking an additional $3 million in mortgage loans. CON regulation requires that a capital cost increase that exceeds the CON approved capital cost plus the allowed inflation factor is required to obtain MHCC approval. Using the building cost indices in effect at the time the modification was submitted, staff calculated an allowable inflation level of approximately $540,000, which is far below the reported project cost increase of approximately $4 million. After review, staff believes that the proposed modification will not have an effect on the Commission-approved CON with respect to cost effectiveness or economic viability of the project. With no change in location, capacity, or nature of the project, the modification will not change the need for the project or its impact on existing comprehensive care facilities. The increase in project costs will not have an impact on costs or charges or the financial viability of the project after completion. And Stella Maris has sufficient financial resources and access to appropriate financing to implement this project. Therefore, staff recommends that the Commission approve the proposed modification of the Certificate of Need issued to Stella Maris, Inc., with the same conditions attached to its 2017 CON regarding Memoranda of Understanding required by the CON Nursing Home Standards. At this time, I'd like to introduce the following Stella Maris representatives here with us today. Steve Bennett, Stella Maris' Chief Financial Officer. Rick Abbott, Stella Maris' architect from Ford Copland Mox. Judith Weiland, Senior Vice President of Strategic Capital Planning and Facilities for Mercy Health Services. And James Buck, Legal Counsel from Gallagher, Avilius & Jones. And at this time, I'd be pleased to answer any of your questions.
Thank you very much, and thank you for your patience. Commissioner, Director, you have an observation.
So the commissioners that are on the line, if you could just, as a matter of course, mute your phones. We're picking up a lot of paper shuffling and key data entry, typing probably, that are quite noisy here in the room. So I think probably the best thing is just to mute your phones, and then when you want to speak, unmute them, because it has gotten to the point where it's hard to hear what's happening here in the room. Thank you.
Thank you. Okay, very good. Do we have any questions for Ms. Hare? Any questions at all? Nothing. Anybody listening in, the commissioners on the line, are there any questions for Ms. Hare on the Stella Maris modification? Commissioner Pollan.
Have a motion to approve the
motion. Okay, we have a motion to approve. Do I have a second? A second. Okay. Any further discussion? Okay. All those in favor of approving the modification for Stella Maris, say aye.
Aye.
Aye. Aye.
Got you all. Any opposed? Very good. You have your modification. Thank you, Laura. That was excellent. Thank you. for the record, Commissioner McCarthy has joined us, as well as Commissioner O'Connor. So for the record, they're here. Okay, thank you. Yes, thank you very much for showing up in this weather. Right now, we're going to have a review of the preliminary draft proposal for modernization of certificate of need. The CON Modernization Task Force met on November 9th to consider draft recommendations to the final report. Commissioner Sargent and Paul Parker of our staff will present the draft recommendations and discuss the next steps. The final task force meeting is going to be held on December 3rd at 9:30 a.m. That's a Monday morning. And the commission will consider the final report on December 20th, at the December 20th meeting. The commission will allow time for interested parties, and I'm sure we're going to get quite a few of them, to comment on the final report at the December 20th meeting. I just want to make a comment about the report. I read the report extensively last night. I think it's an absolutely terrific piece of work. It has covered a very, very broad field. I was particularly impressed with the overview that you have all done in terms of looking at the professional economic literature on certificate of need, which is, I think, for not only for our commission, but also for members of the state legislature, will be very edifying. So thank you very much for your work on this. And gentlemen, the floor is yours.
Thank you very much. And I want to take a moment to thank the task force and the staff. It's been a lot of hours. I would like to sit down and say, I wrote this report, I wrote it myself, but absolutely not. And it's been a great deal of effort by a lot of input from those in the community, a lot of hard work from the staff. And I think what we're going to show you today are a preview of the recommendations so that they're not new when we come back and we have to vote on them. But it's a menu of recommendations that have been vetted with different stakeholders that I think you'll find more consensus around than I would have predicted at the start of the process, and that are meaningful. So I think it's, at least my impression is that it's a good result. I don't know, Paul, if you had anything you wanted to talk about beforehand. Do you want to dive into the context? Or?
Sure. So what we've laid out here in these draft recommendations is really three tracks. We have some actions that we're recommending here that we would proceed on immediately after we have approval of the plan from the commission, and these would be actions that we would not need changes in the law to implement. So this primarily would involve updating and modernizing our regulations. The key regulations are state health plan, which we use as a set of standards for reviewing projects, and the procedural regulations. We will, as we always do, try to build consensus among stakeholders on these changes. The staff workload would be significant because we will still be confronted with the same scope of CON regulations and the same range of facilities and services that we have to regulate. We note here that it can take 9 to 12 months to rewrite a state health plan chapter. I think there are some possibilities to maybe shorten that procedure, but this is not going to be something that will happen overnight, as I think all of you are aware. And we will hope to use consultants effectively to assist in this work. Statutory changes that we are recommending here, obviously, we would be working with the governor in bringing those recommendations and changes in the law forward. I think building consensus on those kind of changes is clearly going to be very important. We have a history in this state and throughout the country of the difficulties of kind of updating and modernizing CON regulatory programs in the face of the
concerns among the regulated industry with these kind of changes. And then obviously those changes would require further work on regulations to implement them. And we have also some recommendations on areas for further study, which have emerged in our discussions with the task force. And these are areas that point to directions we might want to take in the future in terms of further modernizing CON regulations. But I think we need to do more work among stakeholders and also among our other agencies of state government to actually see if we can come up with feasible ways to take on those kind of changes.
And I think the reason this is a good structure is we have control over that first category, meaning we, the commission, we have to make sure the staff resources are used wisely, but we can come up with a plan to implement those without action. The third category, in some senses, are the most ambitious set of things, but there was a lot of discussion, why do we need CON in particular areas? And in many of those areas, the answer was because we do need someone to make sure that the people in the industry meet qualifications and standards. So maybe what we need to have is a broader discussion of, is that still CON, or is that licensing, or do we take CON and limit it down to its purpose, even if we keep it? So it has a consideration beyond just CON. So the reason the category 3 is we feel like before we got to a solution, we see the problem, we can narrow CON, but it involves an area outside just us. So.
Have any questions on that?
So we can go quickly through the recommendations, and if you have any questions as we go along, let me know. So the first one is just identify the state health plan chapters that are most in need of updating, which offer the greatest potential to meet reform objectives and prioritize their revision. It's hard to argue with that one outside of resources. We would like to see a shorter cycle time on our revisions, and some of the state's health plans are quite old. So 1A, all right, the proposal is to limit the state health plan standards to consideration of project need, viability, impact, access, and applicant qualifications. The idea here is to take down, to the extent you can within the statute, because you have to look at certain things, but every time you add something to be looked at that's not central, you require the folks on the staff to make a decision one way or the other so we can make a reasoned decision, and the process multiplies on itself. So by focusing on what we need to decide and removing extraneous things, we can speed the process up and speed the workload up. So standards that don't address those criteria would be only included if absolutely necessary to the particular characteristics of a healthcare facility, and we would eliminate or redefine standards that have low impact. The 1B is to revise the performance requirements for approved projects to consist of deadlines for obligating the expenditure and initiating construction, to eliminate project completion deadlines for construction projects, so that if you can get a 12-month extension if you don't construct it, and then you can report progress on this one. I'm sorry, I'm struggling with this one. You want to cover this one?
Right now we have rules that actually establish set time periods for certain project categories to be completed. What we're talking about is eliminating that, really having a set of procedures that would focus on kind of the important step, which is getting projects obligated, and if they are construction projects, get that construction initiated on a timely basis. So in some ways, I think we would want to maybe be a little tougher on that, but once you've got a project under construction, we would eliminate the quarterly reporting requirements that we have now, and we wouldn't have this ultimate deadline that can't really be extended except under limited circumstances. We would simply let people proceed and just annually get a progress report to make sure the progress is the project is proceeding on a reasonable basis, and give them another 12 months to go forward.
Thanks. And then 1C is simpler. It's basically when there's review, changes and approved projects, to the extent we can, have that be a staff review function with approval by the executive director. I think as you've seen in the ones that have come back to us where there's modifications of the project, you know, we haven't really been turning those down very aggressively, have we?
Director?
Paul or Commissioner Sargent, correct me if I'm wrong, but the two cases, the two modifications that came forward today would be examples that under this change would be able to make the staff decision.
Yeah, we haven't quite got to the slide yet, but one of the statutory changes that we've included here in our draft recommendations is that we eliminate the capital expenditure threshold feature of CON review for all facilities other than hospitals. We've got some ideas on modifying it in that area, but Ben is correct. In this case, with a nursing home and with a hospice, these projects that you heard about changes to today would not have required a CON in the first place, so obviously they wouldn't have to be back here with changes to the CON.
So going on to recommendation 2, on the next page, we are looking at two things here that would integrate better with what the HSCRC is trying to do, so we can get out of their way as they're working on the state model. The first one is create a waiver of CON requirements for hospital capital projects endorsed by the HSCRC staff as a viable approach for reducing the total cost of care consistent with the total cost of care model. The second one is a docketing rule allowing consideration of a proposed project that offers an alternative model for post-acute care endorsed by the HSCRC staff as a viable approach for reducing the total cost of care. That second one, where it's a docketing rule, there was some discussion in the work group and some concerns about that. What that means is currently we wouldn't let the application be docketed. You sort of do this initial, there's no need, we're not opening the docket. You would still go through and get the approval under the standards this way. We can't just hand it out without doing the analysis. So we're waiving it to the extent we can as a docketing rule. The next group, that's all we have for the group 1. Into group 2, which are the statutory changes that could be implemented starting now.
Randy.
Yep.
Yeah, this is Commissioner Metz. Back up that last slide there.
Sure.
Yeah, there was some significant discussion on the docketing rule allowing consideration. Yeah, on the second part of recommendation 2.
Yes.
Yeah, I think it was kind of surrounded a little bit of pretty extensive discussion that hospitals had previously been in this arena mostly through the extended care model, and I think there was some fear that hospitals would re-enter that, developing an unfair advantage or a non-competitive model by opening up beds without a CON. And I know that Mr. Grimmel had some discussion with that in the last task force, and there are some concerns that may be a little bit too broad.
Yes, I do agree with that. I think the concerns, because also there will be a recommendation in the future to actually open it rather than a docketing rule to actually make it so they can do it without a CON. That's probably more of the legislative proposal as opposed to here where it's just opening the docket and still doing the analysis. So
right.
Under the regulatory piece, the hospital would still have to get the CON.
Right.
But the docketing rule would be waived. But
I just wanted to mention that. Thank you.
Sure. And I should take a moment to thank Commissioner Metz, Commissioner Hasey, all commissioners who have sat and helped me through these various task force hearings, or not hearings, but discussions. The input has been invaluable. Also, Commissioner O'Grady. Yes, Commissioner O'Grady as well. I'm sure I'm missing someone as well. I tried to do my best to be one of the chief cat herders. I think at times I've been maybe the chief cat, but being herded. But the assistance has been great. So the first recommendation for legislative action is, as Paul mentioned before, eliminate capital expenditures for requiring as an action requiring and approval for all provider categories except hospitals. The only projects fitting the categorical requirements of new healthcare facility relocation, change in bed capacity, introduction of new medical service would continue to require CON regardless of capital expenditure. So once you get in, if you're not a CON required, we don't require you when you get to a certain dollar amount to get a CON anymore. Number 2, replace the existing capital expenditure threshold for hospitals with a provision that hospitals must only obtain CON approval for a project if the estimated expenditure exceeds a specified proportion of the hospital's annual budgeted revenue, and they're going to request an increase of its global budget revenue. So it makes sense that currently, instead of a hard dollar figure, how big is it relative to your size, and are you going to seek to recover it in your rate?
Randy, is it all right to have a discussion at this point?
You certainly can.
Sure.
Okay. The only thing I would say, and it's more a procedural sort of thing, I think recommendation 1 and recommendation 2 are significantly linked. And so I think as it comes to us and thinking about how to bundle these things and vote them, I would hate to have it that we eliminate the one without number 2's replacement, because that's really what's going on here. I think, unless you have a different interpretation of the discussion, that what we're talking about is kind of updating and modernizing, not just eliminating the current standard.
I think that's a fair point. I had sort of envisioned these as a suite of, these are all recommendations to proceed, like they're just different channels because of different ones they are. So we haven't gotten into, I guess, alternative scenarios of some, but not all. But I think we could implement all of these recommendations.
I just think they're linked enough that I would hate to have them kind of be considered on their own without, that you end up in a situation where there's sort of, we're implying to the legislature that they can eliminate, do number 1, eliminate, and I think the sense of the group was you eliminate in recommendation 1, but you replace in recommendation 2. So I think just in terms of, having seen legislative weird interpretations at the federal level, I'd hate to see the two not inextricably linked to one another. That's all. We can certainly discuss it in the future meeting when this comes up more for, well, I don't know. Is this when we're going to vote on these recommendations?
We are not going to vote today. I'm just giving a preview so we all have a chance to mull it over, because we want everyone to feel like they've had a chance to think about these. It will be our
great. Thank you.
Recommendation.
Got it.
Recommendation 3.
Wait a minute, Commissioner O'Connor.
I'm sorry. Go ahead.
Clarification, Randy, on page 8, number 3, you talk about changing medical services approved to be provided by the facility. Would this require a limit required change review? Yet on page 11, you say any change in introduction of new medical service still needs a CON. I'm just a little confused about what you mean on page 8, number 3, change in medical services.
So
that would not need approval, formal approval.
So on page 8, what we're saying is we would limit required change reviews. So we're talking about a CON that's been issued, an approved project being implemented by an applicant, but they come to us and say, there's a medical service, and that's a defined list of services in the statute that we want to introduce, and we made that decision after you gave us a CON. But now that we're doing this project, can we change this project and add this as a change in what you approved?
Doesn't that conflict with page 11?
No, I think, Jerry, as I read the page 8, is what we're saying is we as the commission would delegate to the executive director the ability to approve that. So they would still come in these applications, and we'd say, well, if you've already got an approval and you want to expand the medical service, we'll delegate it to the executive director, and maybe it only comes to us. It's a big deal. On page 11, I'm reading that as introduction of a new medical service for a hospital.
It could be other facilities. So we're talking about two different things here. We're saying, in getting a CON, you're coming to us with a project that you want to approve. Introduction of a new medical service, the way that is defined in the current statute, would still need a CON. We're just kind of telling you here on slide 11 what would be left if we got rid of the capital expenditure threshold. And what would be left would be what we call categorical projects. You're doing a specific thing that the law says requires a CON, and no matter what it costs, you need to get a CON.
But like adding neurology to an already existing medical service, you would not need a formal CON. Executive director approval. You already have medical services, say, and you want to add neurology to the service.
Neurology is not a medical service as defined in the statute. What we're talking about here are in the hospital world, for example, if you wanted to introduce an obstetric, an inpatient obstetric service, your hospital that has not delivered babies in the past, but you want to start doing that, that's on the list. That requires a CON. You want to introduce a formal pediatric inpatient program that you haven't had before. That's on the list of medical services. Psychiatric services, introducing those as a new service.
Why is it neurology?
So, but correct me if I'm wrong. Like with this recommendation on page 11, it talks about when you need a CON. On page 8, it's talking about you may need a CON, but in certain categories, we've delegated the decision to the executive director. So, in other words, they do that because you say if you're not exempted from the process altogether, under 11, you got to go through the process. We've just changed under 8 the process in some cases is to go to the executive director rather than the commission. Does that make sense?
So just to sort of anchor this, recently we've had some oncology centers that exceed the capital threshold. They come before us as approvable projects, but they are not under the services that are categorically require a CON under this recommendation. That would, as long as they did not exceed the elevated capital threshold, assuming this is a hospital sponsored project, they could go forward with that as long as it was consistent with the GBR arrangements with the hospital, et cetera. So some of those would fall away from our workload as a result of should this change. That could happen today, but the threshold of $12 million is probably too low. It's my recollection that some of the recent oncology, the radiation oncology programs facilities that have started have been more in the ballpark of about 20 million. So that triggers, they're over the cap, they come before us.
And not to complicate anything further, but in the hospital world, the capital threshold that we've had historically has been quite different for hospitals. Hospitals, unlike other facilities, have always had the ability to do projects that don't fall into any of the specific categories that require review. And they can be quite large projects, quite expensive projects, and they do not need a CON, even though they exceed the capital threshold, which has been indicated for hospitals. Currently, it's about $12,500,000. By taking the pledge, that basically says we're not going to seek any adjustment in our rates to help us pay for this project. The problem we've encountered in recent years is that hospitals don't take the pledge. This is the type of project Ben was alluding to. They come to us, they say, we want a CON for this capital expenditure that exceeds the threshold, we're not actually looking for rate changes right now, but we want to get our ticket punched. So in the future, if we want to be able to go to HSCRC and get some more money to help us pay for this project, we have that ability. So we're really trying to kind of eliminate that approach to regulation. And basically with this recommendation for hospitals saying, first of all, we're not going to have a fixed dollar amount. If you're a big hospital, your threshold is going to be big. If you're a small hospital, it will be smaller, so it'll be based on your revenue. And secondly, no matter what the expenditure is, if you're not actually looking to get higher rates to help you pay for it, then you don't need to get a CON.
So recommendation 3 was to change the CON statute, and this will be for all categories now, to limit the required considerations on a project review to consistently with the state health plan standard, and that includes actually the gatekeeper role as to who is seeking the CON, because that's not explicitly listed here. It's in the state health plan standard. The need for the project, viability, impact of the project on access to care, impact on costs and charges, and compliance with the terms and conditions of previous certificates.
I think one of the important things that I would want to say here is that you'll note that we're explicitly saying impact on access or impact of the project on costs and charges. So unlike what we currently say on our regulations, we're not saying impact on other providers of the service. So we're trying to, conform the criterion problem to not focus on competitive impact so much.
Thank you. So recommendation 4, expedite CON review of changes in bed capacity in existing alcohol and drug abuse treatment intermediate care facilities and residential treatment centers. And Paul, you may want to talk about this one. We have proposed similar changes in the past.
Certainly with the first category of facility. So these are 2 categories of facility that we felt that there was merit to the idea of allowing these existing facilities when they're up and running in Maryland to expand capacity as needed. We don't think there's a lot of downside risk to freeing up the ability of those types of facilities to implement that type of change. But as noted on the slide here, this is something we're still discussing with the task force, and there are clearly some issues with respect to how much you can deregulate in this area for existing providers of the service, but continue to have a higher regulatory hurdle for someone who wants to come into Maryland as a new provider of the service. We want, I think, CON regulation to be equitable. There's certainly, merit to having, kind of a level playing field, but we're interested in at least exploring the opportunity for deregulating in this way for some facilities.
And then recommendation 5 was to eliminate changes in acute psychiatric bed capacity by general hospital from CON review, while retaining changes in bed capacity at freestanding special psychiatric hospitals. Similar, I think, concerns were raised there about not wanting to make it too hard for people to enter the market while freeing up people already in the market to do what they like. I think there's a concern there. It's balancing, though, how hard it is to get a CON, too. If you make the CON focusing on the qualifications of the person, then it might make sense to say new entrants need to have their qualifications vetted, but we're not imposing economic burdens that are unique, that aren't already imposed on people who have a CON. So I think there's a balancing test. So recommendation 6, eliminate changes in general hospice bed capacity from CON review by an existing general hospice. In the same vein, recommendation 7 was to define an ambulatory surgical facility as an outpatient center with 3 or more operating rooms instead of 2 or more operating rooms. determination of coverage process administered by staff to review the proposed establishment of outpatient surgical centers with no more than 2 operating rooms. Apply the rule equally to all persons, regardless of ownership or organizational structure. So hospitals, physicians, joint ventures involving hospitals and physicians, other types of corporations will all be eligible to establish outpatient surgical centers with up to 2 operating rooms. Recommendation 8 was to limit the requirements for CON approval of changes in operating room capacity by hospitals to the rate-regulated hospital setting, i.e. general hospital. Any other facility would have the ability to establish 1 or 2 room operating room outpatient surgical centers without CON approval. So this fits with regulation, recommendation 7. The MHCC could issue a determination of coverage after plan review by staff and notification to HSCRC that the hospital's CPR may need to be reduced if they are doing outpatient operating rooms.
So I would just mention that, on 7 and 8, earlier this year, we did implement new state health plan changes that allow some types of providers to actually escape the need for a CON to develop a 2 operating room facility. We went as far as the current statute allows. What we're proposing here is to really open up the possibility for developing 2 operating room ambulatory surgical facilities for everybody in the state. So that would be hospitals, any types of joint ventures between physicians and other organizations. Basically anything that would facilitate the ability to get outpatient surgery done in the lower cost setting, the unregulated outpatient surgical setting. And we can't do that now under current law because of the restrictions that are put on hospitals changing their capacity without CON.
So the final group is the 3 recommendations. Go ahead, man.
So I think it's probably important to emphasize that recommendation in 7 and 8 has generated some questions from HSCRC, so we'll be working back and forth with them before the final recommendations come forward. They want to better understand how these expansions in unregulated capacity might lead to utilization shifts from the regulated setting, and how the hospital global budgets ought to be adjusted more dynamically to reflect the shift in utilization to unregulated and lower cost settings.
So the final 3 recommendations are sort of, in a way, the biggest ones. They all involve other stakeholders that I think we would want to involve before proceeding. The first one is for home health, hospice, alcoholism and drug treatment, and residential treatment center sectors. The primary reason for CON that was articulated over and over again was that gatekeeper role of looking at the entity or the person that is going to be providing the service, in which case we could have a CON. It's not really a certificate of need. It's almost a certificate of, are you an adequate provider or an appropriate provider? Or you could use a licensing scheme run by the Department of Health. You wouldn't pool the CON and not beef up the licensing scheme. Like, in other words, there wasn't really an appetite to just lift one and not do the other. So there is a discussion to be had if you narrow CON to those categories and keep it in place. If you beef up the licensing side, you could make an argument for either one. So that first recommendation is to proceed to have that discussion and figure out how to narrow the range so we're overall appropriately regulating for what the need is. Recommendation 2 is to engage on further integration of the CON review and the total cost of care project. The objective here is to limit hospital projects requiring CON review and improve the use of HSCRC expertise in consideration of project feasibility and project and facility viability, because they're looking at many of the same things when they're deciding how to put it in the budget that we're doing when we're deciding it's a viable project. Why prove it twice? Recommendation 3, consider structural changes in how the commission handles project reviews to incorporate a commissioner or a project review committee. rather than single commissioner reviewers and then bring it to the whole committee. So looking at ways to structure it that maybe streamline at our level the reviews so that they can move more quickly. If anybody has any questions, that was the preview, and then we will have an opportunity to hear comments and discuss it in the future.
Yes, Commissioner O'Connor.
Randy, what impact does this easing of requirements for number of beds in the surgery center, what impact will that have on the total cost of care coming down the road? Isn't it going to increase total cost of care, shifting from regulated to unregulated, where volumes in unregulated areas will increase? Insurance companies won't like that, right?
I think part of the theory of why you might not feel that you need CON these days is the insurance companies, the payers, aren't really relying on CON to keep volume down, right? They're looking at medical necessity, medical policies, and appropriate care, is working with providers and members on education. There's a whole group of tools in the tool bucket of the payer community, none of which relies on CON. But so generally, the cost differential, it's much cheaper in an ASC to provide those services than it is in a regulated space. So you have the cost savings by moving in. And unless you feel that there's going to be a whole bunch of medically unnecessary surgeries that result, then we would be happy to have them move out of the hospital.
But I thought the hospital gets GBR money plus the insurance company is going to pay for that patient in an unregulated location. Is that like double indemnity, so to speak?
From our perspective in the GBR, the rates are still set and we pay the hospital rate. In other words, the GBR is sort of set for the hospital, but we still pay the payers still pay the fee for service. So moving it out on an individual case to an ASC from the hospital would be cheaper. And then the budget could be appropriately adjusted by the HSCRC. If the hospital is moving a lot of business out of the hospital and it doesn't need to be there anymore, you might think the GBR should come down.
No, but let me follow up on this. The overall cost would come down, would it not?
That would be my belief. Yes.
I mean,
right.
If basic economics means anything, that's what would happen.
Right.
I think also is that a lot of these, like surgical procedures, are a really good example. Really should be done in an outpatient setting. I mean, that where things have gone over the years, it allows you to be done in a lower cost setting, and some of it has not moved yet. And so this new total cost of care is really going to make that happen, because there's going to be too much risk to allow these to continue to be done in the hospital, when in reality they should be done in the outpatient setting. So I think it's almost going to happen without us doing a lot anyway. So allowing this to happen will certainly help the overall total cost of care, no question. I mean, it's going to be some big savings. I think that'll immediately happen just from doing that.
And Commissioner Pollack may be able to say this more eloquently than I think there's some savings and efficiencies when you go from a one-room facility to a two-room facility, in terms of being able to operate both rooms and set them up and have the mechanics of how it works. That if you go to 3 and 4 and 5, the marginal efficiency savings are going down. But 1 to 2 is a big efficiency savings that by itself was a part of the reason for proposed change. Well.
Okay, this may be a naive question, but I'm looking at this from a patient safety point of view. So we're encouraging more ambulatory care centers. What's the criteria for what should be moved into a ambulatory care center as opposed to where the patient is better off in the hospital?
Commissioner Pollack?
There are published, there are pretty standard criteria as to which patients, what cases can be done in ambulatory surgery centers. And there's pretty good evidence that the safety rates for surgery in ambulatory surgery center is equal to or exceeds that of cases done in hospitals. Obviously, there are some adjustments that need to be done for that, because cases that get done in hospitals tend to be more complicated cases with more complications, which is why they tend to why risk adjustment is necessary. But in general, the safety records of ASCs have been pretty stellar. There have been a couple of reports that to the contrary, but none well controlled.
Mr. Director.
Yeah, I mean, and I think what Commissioner Pollack said notwithstanding, ambulatory surgery space has been one in which public reporting has been pretty limited to date, both in terms of patient satisfaction and safety, but that's starting to shift. I think we shared with you the recent Leapfrog announcement that they're planning to pilot a limited initiative to engage a small group of ASCs in safety reporting with the intent of taking it more broadly. We are also looking at it in collaboration with what Leapfrog is doing, expanding our public reporting on ASCs. So there would be additional information available to consumers, not only on cost but satisfaction at ambulatory care, ambulatory surgery centers, which I think is really important as you move more and more of this volume. Anesthesiologists have been also pretty vocal in arguing that they are key advocates for working with surgeons in identifying appropriateness, that they play an important role in flagging patients that may be questionable, and we look forward to continuing to work with them, while we're also recognizing that there are also inherent conflicts in the reimbursement models that make some anesthesiologists less enthusiastic about delivering services in an ASC as opposed to a hospital.
I might think sort of my sort of egg-headed procedural aspect too, since I'm not a medico. One thought about when we get to things like quality of services, CON is a very bad tool for that, because you can look at a fixed point in time, decide if the person has like shady connections in the past, but you're done. You give out a CON and now you're finished. So to the extent we have an ongoing concern with, are these facilities being used medically appropriately, and you look at the potential regulatory tools out there that you might use, you would look at licensing, or you might look at standards of care that doctors should use, things like that. But I wouldn't suggest CON because it's so limited in time, and it has no mechanism to come back and see if anybody, once the people who get a CON are in there, they could be doing anything they want as far as CON is concerned, because they've just got their approval to build the facility.
Yeah, but I'm just concerned about after CON, to build these facilities, you have to be able to have enough income coming in to sustain it. And it's, there's a push to have more and more surgeries outside the hospital. The only concern is those surgeries that are complicated enough that should be in the hospital.
Are there any regulatory bodies for surgery centers?
Well, surgical facilities are licensed just like hospitals in the state of Maryland, so they're subject to the same, licensure inspections and survey inspections, complaint inspections that a hospital would be.
The Joint Commission supervises surgery centers?
Most surgical facilities are accredited, not necessarily by the Joint Commission. There are other accrediting bodies that are the primary organizations used by these facilities. So with all of these changes, none of them really involve moving the site of service from a regulated facility to a wholly unregulated setting. What we're proposing to do is restructure CON so it will be possible for all types of persons and organizations to more easily develop outpatient surgical settings because of the cost advantages of that. But these facilities will all have to be licensed by the state of Maryland and subject to those regulations.
There are no further questions. Thanks for your time and attention.
Thank you very, very much, gentlemen. Wonderful job. Thank you. Next, we will have a presentation on the performance of Maryland in terms of total cost of care. On November 8th, the Network for Regional Health Initiatives released its third annual report comparing the total cost of care among privately insured Americans in 6 healthcare markets, including Maryland. Maryland's performance was favorable for the third consecutive year because of lower prices, relatively speaking, and somewhat lower utilizations. So this has been, in terms of cost control overall, an impressive performance by the state of Maryland, and it's something we should be proud of. However, there is a problem, and Ken is going to talk about that, but more worrisome is the continued finding that Maryland's privately insured population seems to be sicker than comparable populations in the other 6 regions. We'll have to dig deeper as to find out exactly why that's true, but Kenneth Yates Trotman, who's acting director for the Center for Analysis and Information Systems, is going to present the findings for the 2016 report on healthcare affordability and the cost drivers. Ken?
Thank you, Commissioner. So I'll start off by giving an overview on the big picture of this project and how Maryland differs in relationship to other regions. We look at Maryland's total cost of care performance and the total cost and risk over the 3 years that we participated in this project. And then we'll look at the frequency asked question. So looking at the big picture, I would like to explain this takeaway in terms of a scenario. So if you take 1,000 patients, and of these same patients, you put them in Oregon, Utah, St. Louis, Minnesota, and Maryland, and you have these patients insured for most of the year, at least 9 months. And at the end of the year, you will expect that healthcare costs of these same 1,000 people will be about 20% less in Maryland compared to the average cost of these regions. Maryland has performed similarly in each region, in each year from 2014 to 2015, where the state's total cost was about 14% and 16% below the average projected rate. How did Maryland differ? In other words, how did Maryland came up with the 20% below the regional average cost? As you can see, the big driver here is price, where Maryland's unit costs were about 14% below the regional average, where we ranked about the same or second behind St. Louis. For utilization, we came in at about 7% below the regional average, where we ranked second behind Oregon. Looking at the risk score, despite performing very well on total cost, Maryland has had the highest risk score, where we were at about 15% above the regional average. One reason for this is due to coding practices, because Maryland has a sicker population than most states. Also, Maryland providers have been incentivized longer than other states have to upcode. In other words, providers may define every opportunity to increase the case risk index or cases of severity because they simply get paid more for it. Clearly, there are opportunities here to reduce healthcare costs by addressing the higher rate of chronic illness in Maryland's private insured population. As you know, this is one of the goals of the new Maryland total cost of care model, to improve population health via various interventions to address chronic illness such as diabetes. Taking a deeper look at performance, we see that Maryland's first place ranking on total cost among regions is mainly due to price, where the state ranked second behind St. Louis. Sorry. looking at Maryland's performance, if we take a deeper look at the performance, we see that Maryland's first place ranking in the total cost among regions was mainly due to price, where the state ranked second behind St. Louis at 14% below the sorry about that. Sorry about that. Where Maryland ranked 14% below the benchmark and second behind St. Louis. We see that the main drivers for the 14% reduction in prices was mainly due to the medical at 19% and 11% below the average for facility inpatient and outpatient respectively. Maryland ranked second behind St. Louis. The main reason for these reductions in facility fees or prices is due to the hospital or payer rating system, which limits the need for hospitals to charge more for services in the private sector to cross-subsidize Medicaid or Medicare. In other words, there was no need for hospitals to shift on reimbursed costs from the public sector to the private sector. For professional services, unit costs, Maryland ranks first at 18% below the average. This reduction reflects a historical trend, as we know for a long time here at MSCC, that prices for professional services in the public sector, in the private sector in Maryland, have narrowed to just over Medicare rates, especially for dominant healthcare carriers. Other carriers in the state shadow price the dominant carrier by paying just a bit above Medicare. This payment pattern is significantly different in the other 49 states, where private payers pay about 15 to 20% above Medicare rates. Looking at the Maryland's performance in total cost from 2014 to 2016, we see that while Maryland performance is very well from 2014 to 2016, where they were about 14% below the average rate and 16% below the average total cost in 2015, and 20% below the average cost in 2016. However, Maryland did not perform well with risk score. We see that in 2014 we were about 9% above the average and 20% in 2015 above the average for risk score, and went down to about 15% above. Well, why is Maryland actually performing so badly? As we said before, it was due to some of it was due to coding practices. But when we look at the 2015 results, we see a spike in the risk score, and that is due to two reasons. One is the delay of the sicker population in our state-based health cost high-risk pool model, which entered the individual market in 2015. Also, the exit of the self-insured plans, which is a younger and more healthy population, and that gives the individual market much more application of the poor risk that is prevalent in this market. So therefore, you have a spike in the risk from 2014 to 2016. However, when you go to 2016, we see a drop in the average risk score, and that means is that these people who have entered the market and had a lot of medical challenges, they have been having care for like over a year. So although their cost or mobility is still high, but they do not require the level of care in 2016 as they did in 2016. Was frequently asked questions that how did we explain the Maryland's low hospital rates and professional services rates? I've already said it before that for the hospital inpatient and outpatient, that is due to the Maryland all care model, where it limits the need for hospitals to shift uncompensated care from the public sector to the private sector. Also, the professional services rates reflect a historical trend, as these rates are at about Medicare, and also we have a dominant payer, which we have a dominant payer in this market, and they pay most at Medicare. So therefore, the other payers shadow price, and therefore all the professional services rates are historically low. Well, one may ask, Maryland price is too low? Well, I would say no, it's not compared to the rest of the ODC member countries. And one would say, how will Maryland respond to this information? Well, we see in our utilization, we were 7% below the average benchmark. So therefore, there is some opportunity here to reduce utilization. MSCC will identify and publish opportunities to reduce utilization by evaluating low value care and choosing wisely in the Maryland commercial population. And also, we will share with other state partners the potential impact of the new total cost of care model on the privately insured population. Regarding prices, we will add more episodes to our total cost of care website, and that will actually increase our transparency as far as prices are concerned.
Thank you very much, Ken. Commissioners, are there any questions for Ken? Yes, Commissioner Reimer.
My question is, and maybe this is just an overall general question, but if we didn't have the waiver in Maryland and the cost had to be shifted down to that commercial payer group, what's that percentage increase? More than 20%?
It would be north of 20%.
Okay.
Because in other states, the cost that private payers pay is about 20% more above Medicare.
So what we're looking at here is as you just said, because we have the all-payer system here, so we're able to basically lower the cost to the commercial payers by stabilizing that cost at the low. But if that, comparing apples to apples, if you're comparing to these other states, they have that cost shifting going on that we don't have. So, I mean, I don't know cost. If you took the total of everybody, including Medicare, and looked at your cost, we probably would be higher.
We probably would be higher.
Yes, okay. I just want to make that point. Thank you.
Yes, Commissioner Boyle.
I do have a question on kind of the reasons for our higher risk score, and I saw that they did go down, but wouldn't some of the other states have some of the same impact to the ACA?
Well, remember that in Maryland we have a overall sicker population. We have like
say like about 30% of Maryland population is African American, and the state average is about 16%. So as you know, that population is plagued sadly with a lot of chronic conditions. So therefore that is part of the reason. Also in Maryland, as I said before, that providers were incentivized to upcode more or longer than other states when we're talking about professional services. So we are starting historically from a low baseline, and we will always be low.
Mr. Director.
So I think the point that Commissioner Boyle raises is an important one, that a hallmark of a high-performing system is that it manages and delivers the care that a population needs, and we shouldn't be. Our scores here look very favorable. In part, our scores look more favorable than they might because our population, based on the risk, are therefore risk adjusted downward compared to other states. But I think we should be pleased with where we are. We should not be completely satisfied that the health system is partially accountable for the burden of disease in the population. Not completely so, but it does demonstrate, I think, more work needs to be done. I think we might say the more sophisticated coding may explain some, but I actually believe the point that Ken touched on, that we really need to focus on keeping our population well, and when they're sick, treating them effectively and efficiently, and that risk score is a concern to me.
Further questions? Any questions at all? Any of the commissioners online have any questions for Ken? Okay, Ken, thank you very much. Excellent report, thank you. Our next item is the update on our quality report website. A second report released on November 8th was a report from Leapfrog, which showed some promising results. Many members of the commission will remember a couple of years ago when we first were apprised of some of the quality problems in the hospital system. A number of you were set back. I mean, it was not quite surprising, really. We had one of the worst hospital readmission rates in the United States. In fact, I think at one point we were at the bottom. In any event, over the past 2 years, we have, the commission staff and working with the private sector, communicating with them, have tried to do what we can to shine light on quality issues and quality problems and also successes. The good news this year is that 19 Maryland hospitals achieved an A or B grade on the Leapfrog Hospital Safety Grade Report. This is a significant improvement from last year's results. Last year, only 8 Maryland hospitals earned an A or B grade. Courtney Cardiff, Chief of Hospital Quality Performance, is going to highlight the updates to the Maryland Healthcare Quality Report's consumer website and provide an overview of the recent Leapfrog results. Kara? Thank you very much.
Thank
or
you.
Courtney, I'm sorry. Excuse me.
Thank
Getting
you
late.
for that very thorough summary. So as you mentioned, I'll talk about 2 different things today. So we'll talk about the overview of our recent quarterly update to the Maryland Healthcare Quality Reports website, which is our consumer-based site. And we'll also talk about the Leapfrog Hospital Safety Grade results that came out last week. So I always like to do just a quick demo just to remind you what the site looks like while we're talking about these changes. We'll give it a minute to load here. But we have a lot of information on our site. So we have to update quarterly and incrementally just because it's so vast. So for this most recent update, we've made several changes. So right here on the hospital guide, we've updated patient satisfaction measures, which can be found under consumer ratings. And we've also made refreshed the hospital quality measures, which can be found down here. And we also have price transparency data updated for the first 6 months of 2018, which can be found if you click on the price transparency button. And another change that we've made is to the health plan guide. So you can navigate over at the top if you click on health plan guide. So the updates this quarter are a little bit different than what we've done in the past. So we've included 2017 HEDIS measures, which you can find. Those are the clinical ratings. So if you navigate over here to clinical ratings, that's where you can find those. And we've also included CAP survey results, which are right here under consumer ratings. So I mentioned that this update was different than what we've done in the past. So NCQA, which is the health plan accrediting body, requires health plans to perform audits of their clinical data each year. And they also require plans to survey members on their experience every year. So in the past, MHCC has engaged with contractors to perform these HEDIS audits and CAP surveys each year, but we focus only on Maryland-only members. But what we found is that the results are really similar to the national report. So we've opted to eliminate the Maryland-only report and only print the national results. And what we found is that, or we estimate that we'll save about $1.5 million over the next 3 years by doing it this way. So we will continue our quarterly updates into 2019. We'll do the routine maintenance that we've been doing so far, but we have a couple of priority areas that we wanted to discuss. So first, we have some planned focus groups. So we want to revamp the site a little bit, think about a redesign. When we initially built the site several years ago, we used ARC-free software for cost savings, but it's limited some of the things we can do. So we're going to try and see how we can revamp. But we're also focusing on the long-term care guide. So in its current state, it looks quite different than some of the other pages on the site. So we do want to focus on that, and we'll also utilize those focus groups that I mentioned to help us with that. And we're also continuing to develop our outpatient guide a little bit further. And one of our priorities has always been promotion. So we have this great site, and we spend a lot of time and resources to keep it updated, but we want consumers to be able to find it and use it and understand it. So we are in the final stages of an introductory video. It's animated that we plan to place on the homepage of our site, and we'll also use it for social media purposes. So we want to share it with you today. It's in draft form. It's pretty close to being final, but we are happy to get your feedback. So it's only 2 minutes, so I'll just cross my fingers it works. Okay, we're gonna restart it and turn the volume up. Okay, sorry about that. So we are we're good, thank you. And it was a real team effort, so we're glad that you all like it. So as I mentioned, there are a couple of tweaks. It's not final, but it should be very soon. And one more thing, so that video was 2 minutes long, and we will have a 30-second condensed version, and that'll be premiering in movie theaters as a preview this holiday season, so Thanksgiving to a little after Christmas. So if you go to the movies, get there a little early. Right. So we're excited about that and our upcoming initiative. So before I move on to Leapfrog, any questions about our recent web update? Okay. I know everyone's tired. So as the chairman mentioned, we've been involved with the Leapfrog hospital safety grades for a while now. But just to give you a quick refresher, Leapfrog did come and present at the commission about a year ago, so we know we've got some new commissioners. But so for background, the Leapfrog Group is a nonprofit organization. It's founded by employers and purchasers. So their goal is to really help drive hospital improvement through transparency and publicly reporting different patient safety and quality issues. So one of their main initiatives is called the Hospital Safety Grades, where they grade hospital performance using a letter scale of A through F. So these grades are based on measures that look at errors, accidents, injuries, and infections. And Leapfrog uses national data sets to calculate the grades. And hospitals receive grades twice a year, once in the spring and once in the fall. But due to the Maryland hospital waiver status, Leapfrog has been unable to calculate scores for Maryland because certain measures were not available until fall of 2017. That's where MHCC comes in. We were able to calculate measures for 7 patient safety indicators and for 3 hospital-acquired conditions using the HSCRC inpatient discharge database. So we were able to provide that information to Leapfrog so that they could kind of complete the puzzle, because at that point, Maryland was the only state that was not participating. So as I mentioned, this is our 3rd cycle. So we've received scores in 2017 in the fall, and spring 18, and now fall of 18 that were just released last week. So just wanted to give you a quick update on how we've done. So this graph shows a comparison of Maryland to the national statistics. So Maryland is shown here in orange, and the nation is shown in blue. So if we just look at the letter A grades, 20% of hospitals that received a grade did get an A, but we are still lower than the national. And if we look at B and C grades, we're on par, we're pretty close. But one area that is obvious is that for the letter D, we have quite a few more than what's seen nationally. So we know that there is still plenty of room for improvement. But to give this a little context, I've also graphed the past 3 reporting cycles, just so you can see where we started and where we are now. So blue represents our initial grades, fall of 17. Orange represents spring of 18, and gray is the current fall of 18. So if we just look at the letter A again, we've gone from 2% to 7% to 20%. So we had just 1 A hospital the first time, and then we jumped to 3, and now we've got 8. And we've seen similar increases with the letter B grade. But moving on to the letter C, we're actually seeing a decline, which is great. I think they're moving more to the left side, those A's and B's. But again, the letter D is remains stagnant. So we definitely need to work on improvement there. And I'd also like to note that this is the first cycle that we've had no F hospitals. We've had 1 in each of the previous reporting periods. So as the chairman mentioned earlier, we've had 18 hospitals improved by at least 1 letter grade in the past year since we've been doing this. And Dr. Thomas is going to dinner. Okay. So I passed out this state rankings list. So this is a late edition. So if you're still on the phone, you don't have this, but it is available on the Leapfrog website. But it just lists the states ranked by the percentage of A hospitals. So Maryland is highlighted on the 2nd page. So we are ranked
number 38 with 20% of A hospitals. So that doesn't sound great on the surface, but I just want to point out that we were number 47 in the spring. So progress.
What is stunning about this is how it defies preconceived notions. 47, the state of Connecticut. Absorb that fact. Connecticut's one of the wealthiest states in the Union, just like Maryland, and they're number 47. Right?
Yeah.
Big deal.
I was going to ask a question about that, Commissioner Moss, because I was trying to look at this list of states, and no matter how I line them up, whether it's per capita income or political persuasion or pro or anti-regulatory or industry or any of those things, it almost seems like a random listing of states.
That's right. And it's also true based on other quality measures that we've had here in the past. Those of us who are ancient denizens of this business remember back in the early 2000s, Maryland's Healthcare Commission started doing a study of cardiac surgery performance. And some of the stunning facts about that is that hospitals that you thought would always be A or B were not necessarily A or B. Actually, some of the hospitals that were in the top rank were not ones that one expected. When Romney up in Massachusetts did a similar exercise, they found the same thing, that you would assume that, the hospitals with these great big names, right, would necessarily have the highest performance, but that turned out not to be true once you start getting into the details. It's not the size of the hospital or its name or its reputation. It's actually what's going on, and that's the case. Yeah, you're quite right. This is, New Jersey. New Jersey's number one, right? So, well, Louisiana. Oh yeah. Well, God knows. I mean, Louisiana's number 12. Mississippi still beats Maryland. But it's not. It's counterintuitive, and it's quite remarkable. Karen, yes, go ahead, Courtney. Any observations? Or?
I have a question. Did the D hospitals remain the same hospitals from the first year to the third year?
Some, but not all.
Okay.
So regarding the state rankings, I also wanted to point out too, there was a slight change in the methodology, which could have a big impact. So if you just look at New Jersey, for example, as number one now, they were number 17 in the spring. So that's that's 16 places. So we'll be eagerly tracking these rankings as we continue to collect the data to see if there is any kind of effect on the methodology.
You don't think there's anything suspicious about that at all, do you?
Well, yeah, I mean, I think there has been, maybe Teresa has some comment on this too, but the methodology did change, and these changes, the quality measurement organizations say they don't matter too much, but when you look at very aggregate measures, such as state rankings, the cumulative impact is greater. So witness Hawaii was ranked number one last spring. They're now down to 20th. One of my personal favorites after Maryland, Minnesota has fallen from 18th to 30th. So they're cumulatively, these are small changes. The rating organizations would say, but if it affects all hospitals in a region in the same, state in the same way, their overall ranking can slide or increase pretty dramatically, as we're seeing here. I don't know if you have anything to add to that, Teresa, but clearly it's still a developing science.
Well, how regulated and uniform is the reporting from these states? I mean,
so the data that Leapfrog uses is all national. So most of it is from CMS Hospital Compare or NHSN HAI results for outcome measures.
but does an outside agency review medical records, or is it volunteered from the hospital to the state?
So hospitals have to they participate in the inpatient quality reporting system, so that's how they report their measures. So, yeah, so there's data validation with those different sources. So CMS Hospital Compare has different data validation. But you're right. I mean, the ranking.
So like, yeah, just like from the grassroots, I mean, reporting an infection, where does that start? Does a nurse report an infection? Does the doctor, the high school graduate in the town medical record do it, or?
So I think most hospitals have an infection prevention team, and their processes are probably internal to the hospital. But NHSN does do data validation, and they randomly sample. Yes, and MHCC has done data validation within Maryland in the past.
And that's on the CDC data, the CDC data, what they say is NHSN, data. So it's not simply taken as is. Maryland was one of the leaders in auditing of the CDC data originally. So we've got a stamp.
So I think the moral of the story is we are improving and we're proud of the progress, but it's clear we have a long way to go, and not just to improve, but maintain. So MHCC continues to work with hospitals and other stakeholders to continue moving forward.
Chairman?
Yes.
Chairman, this is Casey Markio.
Yes.
Is it possible in the future if we could, is it possible in the future if we could start evaluating these surveys by region to see if there's any inequities between regions of our state?
Oh.
Yes, I think that'd be very easy to do. By that you mean the Eastern Shore, on average, perform better or worse than Western Maryland or the Central Maryland in terms of the quality that is achieved at hospitals in those areas. I think that's pretty easy to do, and we'll even think about whether we can get that to you in the next couple months, because we have the data to do that. We just haven't aggregated that in that fashion, but I think it is possible. Not wanting to overcommit staff that are already feeling overcommitted, but I think it's possible.
Yeah, and I think it's something that we've talked about. We just haven't done a deep dive to that level just because we haven't had enough data points at this point, but something we can definitely consider.
But I mean, a general question that I did look at was rural-urban separations, and it's true that I think our A hospitals are largely larger community or academic medical centers, but that does not mean that it's impossible for a smaller hospital to perform well. And there are several that fall into that category. I think St. Mary, MedStar St. Mary, is a hospital, if I'm not mistaken.
Yeah.
Small.
And one more thing I just want to point out too, so there are a lot of different sources that rank and rate and grade, and they're all a little bit different. So U.S. News and World Report, they have their own gradings. Health Grades has their own rankings. So I think it's important to just pay attention to what we're actually looking at. So in this instance, infections and accidents and injuries.
Okay. Any further questions for Ms. Carter? Courtney, thank you very much. Okay. Ben, would you like to share what is facing us in December?
So I think you've had a prelude to what you will be facing in December. Megan talked about the report that MHCC is doing jointly with MIMS on approaches to engaging EMS through different new delivery options. That report will be presented in December. We also will have the final CON recommendations before you, and we'll need to reserve some time for comment. I'll be working with the chair to determine what would be appropriate for commenters. We would, for those that remain, encourage letters rather than simply verbal testimony. But absent letters, we would accept that from anyone who wants to speak. It probably is not going to be as much time. We'll follow the legislative rule, likely between 3 and 5 minutes of speaking time maximum for any commenter, encouraging them to speak as collaboratives as opposed to, I would be uneasy if we had 46 hospitals all commenting, and I think that they're very skilled hospital association representatives could convey the sense of the hospitals in the association quite well. So we will also expect to have a couple CONs before you. I'm not necessarily willing to say where they will be, but one likely would be we hope to have an exemption and one CON decision to bring before you in the month. So given the hearing, it could be a lengthy meeting. If we have our normal December agenda, which December is typically a busy meeting, so we'll be looking at what we can push to January if we have to, as I anticipate the commenters would take some time. We'll hear that first, then you'll hear the recommendations and take action on the final report.
I'll just simply add to that, December is going to be for the commission, given the responsibilities we have, a very, very important commission meeting, because we're talking about making major regulatory changes in a program, the Certificate of Need program that is almost 40 years old. So these are big changes, and so study hard, think hard about what you've seen today and read today, and be prepared, because it's going to be a very, very important meeting. All right, with that, all good things come to an end, including Maryland Commission meetings. So I would like to entertain a motion to adjourn. I have a motion. I have a second. There's no further discussion, I assume. All those in favor say aye. Are any opposed? Okay, that's fine. Everybody can go to dinner. Thank you very much.